me to give this talk about surgical transcatheter treatment of mitral regurgitation. I'd like to thank Marcio for his kind invitation about this topic. I'm very pleased to be here, and I hope to give my contribution, sharing with you some thoughts about this, let's say, very interesting and timely topic to me.
Just speaking some words about Professor De Bonis. Professor Michele De Bonis is an important doctor from Europe. He now works in the same hospital that Dr. Alfieri. He did his graduation in the Catholic University of Medical School in 1993 in Rome. And he did his training in cardiac surgery from 94 to 99. In the last year, between 98 and 99, he did his graduation in St. George's Hospital in London. And now he is chairman of the task force of mitral and tricuspid from European Society of Cardiology. And he's past chairman of the working group on cardiac surgery of the European Society of Cardiology. Is everything right, Professor?
Yes, I'm currently working here in San Raffaele. I'm an associate professor of my university, Vita Salute San Raffaele, and I'm the director of the training school in cardiac surgery, again in the same hospital and university, and chief of cardiac surgery innovation and research in with the co-workers you had the pleasure to meet when you came to us, Marcio.
So please, today Professor De Bonis will speak for us about functional and degenerative mitral regurgitation.
Thank you very much. Thank you very much. So let's try to have the first slide. That's perfect. Thank you very much. So, surgical and transcatheter treatment of degenerative and functional mitral regurgitation. The first thing I would like to focus and underline is that we will mainly focus on functional mitral regurgitation. But I think that since nowadays treatment of mitral regurgitation has to be performed considering all the available options, which are conventional procedure, minimally invasive surgery, transcatheter interventions, I think it is worth it to say a few words also about degenerative mitral regurgitation, mainly to try to emphasize and underline what should be, in my opinion, very clear, which is the fact that there is a huge difference when considering alternative to surgery in terms of transcatheter treatment, depending on the degenerative or functional etiology of MR. So we need a tailored approach. We have to choose the best option for the patient. But if we are dealing with patients with degenerative mitral regurgitation, the European guidelines, they clearly state that surgical mitral repair represents the preferred technique, particularly when the results are expected, of course, to be durable. And the reason for that is that we know since many years that surgical repair of degenerative mitral regurgitation is the only operation which is able to restore a life expectancy at any age, which is back to normal. So you see here in patients who are younger than 65, between 65 and 74 years, older than 75 years, and you see that after mitral repair for degenerative mitral regurgitation, surgical mitral repair, the life expectancy is superimposable to the expected life expectancy of the patients of the same age who had no, degenerative mitral regurgitation and no surgery. So basically, mitral repair restores normal life expectancy. To get that result, it is very important that surgical repair of degenerative MR is timely, and is optimal. Optimal means that after the procedure, no residual MR or minimal residual MR should be present. And the other very important point is that the repair should be durable. Why this is important? Those are data coming from the Mayo Clinic, which clearly show that if after mitral repair you have some degree of residual mitral regurgitation, you see that already at 5 years, about 1/3 of those patients, they do develop significant regurgitation as compared to those who are discharged with no or trace residual MR. And why this is very important? This is important because it has a major impact in terms of survival, so prognosis. Those are patients after mitral repair who have no recurrent MR, and those are patients with mitral regurgitation recurrence. You can clearly see that at long-term follow-up, here we are talking about 15 years, of about 15 years of follow-up, the overall survival is completely different. So surgical repair of degenerative MR has to be performed timely. It has to be performed in such a way that no MR recurrence should be observed in order to improve the prognosis of the patients and restore normal life expectancy. Now, the rate and also the durability of repair depends on many factors, including, of course, etiology, of course, valve anatomy, but probably the most important factors is represented by surgical expertise. And this is clearly been demonstrated over the years with many publications. This is an editorial comment by Mark Gillinoff from Cleveland Clinic, and I think that most of us would agree with this statement. Mitral valve repair is a specialty. It's basically a subspecialty of cardiac surgery. So you need a lot of expertise, you need training, you need high volume centers. And when you look, for instance, at 41 centers, cardiac surgery centers in New York State performing mitral valve surgery and, of course, mitral valve repair, and you look at the patients with degenerative mitral regurgitation, you see that if the patient is referred to those two centers, the probability of having their valve degenerative MR repaired is very high, is almost 100%, higher than 95%. But in the vast majority of the other centers, you see that the repair rate, still for degenerative, pure degenerative MR, is very variable, going from 30% to 50% in most of the cases, up to 80%. So really the expertise of the center is playing a major role in, let's say, determining the repair rate for the specific patient. If we look at the same data, for instance, in United Kingdom, those have been published a few years ago, you see that out of about 40 centers in United Kingdom, the repair rate of these two centers is 0, basically, just mitral valve replacement. And you need to be referred to one of those 6 centers to have a probability which is at least 80% of having degenerative MR repaired. In the other centers, the repair rate is significantly lower, and for some of them is, as you can see, 40%, 20%, or no chance at all of having the valve repair. So certainly, repairing degenerative mitral regurgitation is a specialty. And if the center has a huge experience in the field, this is a series published by Taran David, you see that the results of surgical treatment of degenerative MR at long term, in this case we are talking about 20 years, are excellent. Here we have a freedom from recurrent severe mitral regurgitation higher than 90% at 20 years, and freedom from recurrent moderate, at least moderate MR higher than 70% at 20 years again in this series. Now, there is no doubt, in my view, that in the future, the evolving approach to mitral valve repair will move from open heart to closed heart procedures through mini thoracotomy or with percutaneous approach. But in the setting of degenerative MR, I think that there is still a long way to go before the transcatheter options will be able to reach the standards, particularly long-term, of surgical repair. If you look, for instance, at transapical neochorde, which is, of course, a way to treat degenerative mitral regurgitation on a beating heart with a small left mini thoracotomy incision, capturing the prolapsing segment of the leaflet and releasing a Gore-Tex cord, which are then attached to the epicardial surface of the heart. By using this technology, which is indeed very promising in my view, still at the moment, for the most simple lesions, which are of course P2 prolapse, the rate of recurrent mitral regurgitation, at least moderate, at 2 years is still higher than 25%. And since we are talking about patients who are operable and patients who have P2 prolapse, these results, of course, at the moment remains suboptimal as compared to the surgical benchmark. Just, I think, last year, we were able to review, for instance, our long-term results at 20 years of quadrangular resection for prolapse of the posterior leaflet. And you see in this graph, which has been recently published in Annals of Thoracic Surgery, that the cumulative incidence function of recurrent mitral regurgitation, at least 3+ at 20 years, in our series was 8.8%. This means that more than 90% of the patients at 20 years, they still have their mitral valve which is competent, or with a recurrent mitral regurgitation which is less than 3+. So those are really benchmark, let's say, and extremely satisfactory results are long term, and this should be the gold standard to which other alternative procedures should be compared when we are thinking about degenerative mitral regurgitation. What about MitraClip in the setting of degenerative MR? We know that MitraClip has been extremely useful to treat patients who were not treated before, inoperable patients, high-risk patients. There are a number of limitations of this technology we are aware about, and I would just briefly focus on the issue of residual mitral regurgitation, which can be somehow, I believe, accepted in the setting of functional MR, but it should be carefully considered when we are dealing with patients with degenerative mitral regurgitation, if, of course, they still are surgical candidates, because those are, for instance, some of the most recent data reported by Soraya on behalf of TVT registry. And you see that the vast majority of those patients had degenerative mitral regurgitation treated with MitraClip. Residual MR, at least 2+ or greater, was observed at hospital discharge in more than 38% of the patients. Most of them had a residual MR 2+, and about 7% of them had 3 or 4+ residual MR. And of course, the conclusions of this presentation performed at TCT in 2017 were that transcatheter mitral repair is effective and safe, but residual MR is still a problem. And residual MR is related to prognosis, even in prohibitive risk patients. And this is clearly shown by this cumulative incidence of mortality already at 1 year. You see there is a significant difference in terms of mortality at 1 year when comparing patients with residual MR 3+ as compared to those who had 1+ or less residual insufficiency. So I believe that according to all those data and more we have available in the literature, of course, surgery, there is no doubt that remains by far the gold standard in degenerative mitral regurgitation. And I believe that the guidelines from that point of view are appropriately stating that percutaneous edge-to-edge procedure may be considered in the setting of severe primary mitral regurgitation when the patients are inoperable or they are at high surgical risk, as assessed by our team. May be considered means, as we know, class 2B recommendation level of evidence C according to the last European guidelines. Now, what about secondary mitral regurgitation? In secondary MAR, the situation is very different, and the question is there still a role for surgery in secondary mitral regurgitation? I believe that there is certainly a role for surgery. There is a role for surgery, and again, the guidelines emphasize this in patients with secondary severe mitral regurgitation who requires concomitant myocardial revascularization and do have an ejection fraction higher than 30%. But surgical treatment should also be considered in patients who are symptomatic with severe secondary mitral regurgitation, even if the ejection fraction is very low, below 30%, but there is an option for revascularization, and there is evidence of myocardial viability. Those are certainly, in my view, surgical settings. The issue with the surgical treatment of secondary mitral regurgitation is that for many years we have been considering undersized ring annuloplasty as basically the procedure to apply to all patients to treat this disease. And we have discovered over the years very clearly that one size does not fit all, which means that if we simply put a very small ring in patients with secondary MAR without a careful selection, then the recurrence of mitral regurgitation, and those are a number of studies published over the years, is very important. You see from 20% up to more than 50% in a number of series. And this one, which is indicated with a red circle, is one of the most recent trials. This is the CTS net trial published in New England Journal of Medicine, where the recurrent rate of moderate or severe mitral regurgitation was more than 50% at 2 years. And we will try also to analyze a bit more in details why this happened. What we have been certainly learning over the years is that a small ring, an undersized ring, is not durable when there is a lot of tethering, when the left ventricle is too much remodeled. And there are a number of markers and parameters. Here you have a list of some of them, which can be used as predictors of failure of an isolated undersized annuloplasty. Basically, they are the expression of the same problem. When the left ventricle is too remodeled, when dysfunction is too severe, when tethering is too pronounced, the ring might be working at the beginning, but it is going to fail in a short to mid-term time frame. That's why we need a customized solution. Customized solution in the setting of secondary mitral regurgitation means that there are certainly patients for whom an isolated undersized annuloplasty can be effective, but they need to be selected. There are patients for whom mitral valve replacement with complete preservation of valvular apparatus is the only option. And there are patients where we can use a ring annuloplasty, but additional procedures at valvular and subvalvular level need to be associated in order to counteract the problem of excessive tethering. So patient selection is the key. Without patient selection, we will not be able really to provide a durable solution in this setting. So in my view, but I think that the data are quite clear from that point of view, isolated undersized annuloplasty can have certainly a role. It has to be performed, in my view, with complete rigid rings, but the most important point is that it has to be reserved to patients in the early stage of the disease, when there are not really important predictors of failure of this type of repair. So this is, for instance, in our institution, a patient operated more than 14 years ago. He is coming back for regular follow-ups, and this is still the echo after undersized annuloplasty 14 years later. You see that this was a durable, isolated undersized annuloplasty, but the reason why it was durable, we will see now why, is that because this patient received a complete ring number 28, but he had also ischemic cardiomyopathy with myocardial viability. He underwent myocardial revascularization. And what is more important is that he had no severe geometric deformation of the mitral valve. The left ventricle was dilated, but not extremely dilated. There was a good coaptation length between the two leaflets after undersized annuloplasty. Concomitant revascularization was performed in presence of myocardial viability, and there was a significant reverse remodeling at follow-up. So you see, this is the degree of tethering of the mitral leaflets, where you see that the coaptation depth was less than 1 centimeter. You can measure the angles, the tenting angles. The posterior one is less than 45 degrees. The distal anterior leaflet angle was less than 20. And you see that at the end of the procedure, with an isolated undersized annuloplasty, there was a very good coaptation length between the anterior and posterior leaflet, which is an important predictor of repair durability. That is the reason why this was a durable repair. The patient, after 14 years, has an ejection fraction about 44%. He had no hospital admission for heart failure, and just mild MR has been documented. There was a significant reverse remodeling after isolated undersized annuloplasty and concomitant myocardial revascularization performed in presence of viability. At the beginning of this year, in January, on the other hand, we had this other patient, 74 years old, occlusion of the circumflex coronary artery with a lateral wall fibrosis. This patient had a better ejection fraction, about 43%, with severe ischemic MR, but there was an extreme tethering of the posterior leaflet. You see here, this was the degree of MR. You see the posterior leaflet is very tethered. You can measure the angle, in this case was 75 degrees, but regardless of the measurement itself, you can see that the posterior leaflet is almost vertical. So you know, by definition, that if you just use an isolated undersized annuloplasty ring in this patient, this is not going to be a durable repair. That is the reason why in this specific case we did not even consider performing undersized ring annuloplasty, but we performed a chorda-sparing mitral valve replacement. Alternatively, you can try to address the tethering by associating to the ring annuloplasty other procedure able to work at the valvular and subvalvular level. And there are a number of them. We have probably no time to go into details. Of course, you can try to pull up the papillary muscle with Gore-Tex suture. You can cut secondary cord. You can approximate the papillary muscle. We have been using with reasonable results the edge-to-edge to counteract tethering. You can enlarge the leaflets, anterior and posterior, or both of them. This is an interesting, for instance, approach proposed by Dr. Girdauskas from Hamburg. You see that in this patient, a ring was positioned, and then Gore-Tex suture were applied to the posterior papillary muscle. And when you pull on the suture, you see that the leaflets are coming up. So you are able to pull the posterior papillary muscle and decrease the degree of tethering at that level. And if you do the same with this pulling on those Gore-Tex suture coming from the anterior papillary muscle, you see again the corresponding portion of the anterior and posterior leaflet coming towards the annuloplasty ring. So this is one possibility, for instance, to counteract tethering. And at the end, you can see here that if you look at the postoperative echocardiogram, there is no residual mitral regurgitation, but you see the good mobility of the anterior leaflet. and there is no anymore tenting area, there is no anymore tethering. So this is something which can be added to the annuloplasty to counteract tethering. Of course, you can associate a number of those procedures. In this small series published from Japan, you see that to counteract extreme tethering, Gore-Tex sutures were used to pull up the anterior and posterior papillary muscle. An anterior leaflet enlargement was performed with a pericardial patch, and then a ring was also associated. And you see that the results in terms of coaptation length between the anterior and posterior leaflet is extremely satisfactory, with no residual mitral regurgitation. Here, the left ventricle looks really very concerning in terms of contractility, but the issue of tethering was well addressed. Where are we now? Well, at the moment, if we look at the American guidelines, they state that from a surgical perspective, it is reasonable to choose chordal sparing mitral valve replacement over downsize annuloplasty repair in patients with symptoms and severe chronic ischemic mitral regurgitation. This is a class of recommendation 2A, level of evidence PR. If we look at the European guidelines, in the European guidelines in terms of surgical technique, it is indeed stated that the valve replacement in this setting should be considered when there are echocardiographic risk factors for residual recurrent mitral regurgitation of valve repair. So basically, the European guidelines, they still suggest that repairing the valve, undersize complete ring to restore leaflet coaptation should be preferred somehow, and valve replacement should be considered just when this repair approach is going to fail because of the presence of predictors of failure, which have been discussed about before. So we are a bit confused by the fact that we have different statements and recommendations in the American and the European guidelines. There is always, of course, an explanation for that, and the main explanation is that the American guidelines endorsed the results of this randomized trial, which was published in 2014 in New England Journal of Medicine, where patients with severe ischemic mitral regurgitation were randomized to receive basically undersized ring annuloplasty versus chordal sparing mitral valve replacement. Now, the trial was not powered for mortality. That's why the end-systolic volume index at 1 year was considered as a primary endpoint. And from that point of view, patients with repair and replacement showed no difference at 1 year in terms of reverse remodeling. Mortality was also similar. What was interesting, however, is that the patients who were randomized, they were not selected in terms of echocardiographic parameters. The only criteria for inclusion in the study, so for inclusion in the randomization, was the severity of MR. So the patient had to have an effective regurgitating orifice more than 0.4 square centimeter to be enrolled and randomized. This means that patients with predictors of failure of undersized annuloplasty were not excluded at the time of the screening. And therefore, at 1 year, you see that the recurrence of moderate severe mitral regurgitation in the repair group was very high, was more than 32%. It was even higher after 1 year, more than 50%, as compared to replacement. Not surprisingly, probably, the main mechanism of recurrent mitral regurgitation was residual tethering in those patients. Even more interesting is the fact that if you look at the patients who had a successful repair, which means those patients who had a repair without residual mitral regurgitation, In those patients, the highest degree of reverse remodeling was observed at 2 years. You see 16 milliliters in this successful repair group as compared to 6.5 milliliters in the replacement group. So the reverse remodeling was almost 3 times greater in the successful repair group as compared to the replacement one. So in my view, what basically we learned from this trial is that selection is the key, and that the failure rate of isolated undersized annuloplasty is not acceptable in patients who are basically completely unselected. At the same time, we've been learning that the degree of reverse remodeling of the left ventricle in successful repair is significantly greater than in mitral valve replacement, and therefore that a successful repair indeed outplays a chordal sparing replacement. The issue is, again, to be able to be very selective, identify those patients relatively early in the history of their disease when still an undersized annuloplasty can be durable. Alternatively, tethering should be addressed with associated procedures as we've been showing before, or if it is too advanced, then replacement should be performed. Of course, patient selection, therefore, in surgery for functional MR is the key. The decision-making process to have a durable repair is certainly more challenging than for mitral valve replacement. A good mitral replacement is better than a failing repair, because the worst we can do for our patients is to provide a repair which is going to fail very soon, and therefore severe MR is not treated at all. But the really best solution is to be able to make a clear and good selection of the patient in order to have a durable repair. If we are able to provide a durable repair, then this, in terms of reverse remodeling, is going to be even better than chordal sparing replacement. What about percutaneous edge-to-edge, basically MitraClip, in the treatment of secondary mitral regurgitation? It is very important that nowadays, eventually, we have data from 2 randomized trials. We know very well the Mitral, which was performed in France, and the COAP trial, which was sponsored by Abbott and recently published together with the Mitral in the New England Journal of Medicine. You see, in both trials, basically patients symptomatic despite optimal medical treatment were enrolled. They were selected according to the fact that they had at least 1 hospitalization for heart failure within the previous year. Secondary MR was classified in terms of severity according to the European guidelines in the Mitral and the American guidelines in the COAP trial. And this, of course, does not help when trying to compare the results. And of course, those patients were supposed to be not eligible for surgery according to heart team decision. Now, what is important is that the primary composite endpoint of the Mitral, which was a composite endpoint of all-cause death and unplanned hospitalization for heart failure, was not different in the medical treatment group as compared to the MitraClip plus optimal medical treatment group. These are 1 year. Whereas in the COAP trial, the primary endpoint was all hospitalization for heart failure. And this, you see, was completely different in the 2 groups. And the MitraClip plus medical therapy ones had a much better outcome as compared to the guideline-directed medical therapy alone one. All the secondary endpoints also of the COAP trial were in favor of the percutaneous edge-to-edge group. Now, of course, before we were a bit confused, this does not completely clarify our doubts. there are some considerations we can do to try to understand better why those differences are so marked between the two trials. One point is that, for instance, from a statistical point of view, the Mitral trial is a relative, let's say, classic and simple trial with a superiority design. The population which was, let's say, considered to be enrolled at the beginning was including 288 patients, 144 per arm. Eventually, 307 patients were included. In the COP trial, the statistic is a little bit more complex and changing, because the sample size was, at the beginning, 2012, was supposed to be of 350 patients. Then an interim analysis of 100 patients, 6 months of follow-up, concluded that more patients were necessary, so this number increased to up 430, and then to 555, and eventually to 610 patients were enrolled. You see that there was a different baseline medical treatment in the two groups, particularly in terms of RAS blocker. In the Mitral FAR, almost 84% of the patients were receiving this type of treatment, as compared to 67% of patients at baseline in the COAPT study. And this is probably the, let's say, most remarkable difference. There was also some difference in terms of diuretic treatment. But what is even more important is that the change in medical therapy during the study involved about 80% of the patients in the Mitral FAR. The magnitude of this change is not reported, but most of the patients had a modification of their medical treatment during the study. In the COAPT trial, on the other hand, significant modification of the medical therapy occurred in about 12% of the cases, and according to the protocol, the patients were kept as much as possible on their, let's say, baseline medical treatment. Particularly neurohormone antagonists, according to the protocol, were changed as less as possible. This probably should be considered when trying to understand the differences in terms of results between these two studies. The other interesting point is that in the COAPT trial, according to the protocol, elective heart failure tune-ups occurring following mitral procedure and prolonging hospitalization were not counted as heart failure hospitalization. And we are not sure whether these tuning up effect had an influence in this important difference in the rehospitalization curve you can appreciate here, which appears evident already a few weeks after randomization between the control and the treatment group. This is another important consideration we should keep in mind. As a matter of fact, there is certainly, generally speaking, a difference in the type of patients who were enrolled. Certainly in the COAPT trial, the definition of severe MR was performed according to the American guidelines, and therefore you see that the patients had effective regurgitant orifice area mean value of 41 millimeters squared, as compared to 31 in the Mitral FAR group. Ejection fraction was similar, but in the COAPT trial, patients had smaller left ventricle, 101 mean end-diastolic volume, left ventricular end-diastolic volume index, and also diameter, end-diastolic diameter of the left ventricle was 62 millimeters as compared to 68 in Mitral FAR, and the right ventricular systolic pressure was also lower, mainly because in the COAPT trial, patients with severe pulmonary hypertension were excluded. So let's say that the COAPT trial enrolled patients with more severe MR, with less remodeled left ventricle and lower right ventricular systolic pressure. Now, to me, this is an important point because the severity of secondary MR at baseline certainly has been playing a role in leading to different results. Particularly if we consider the fact that after MitraClip, residual recurrent mitral regurgitation is not completely abolished, is still present in both studies. If we look, for instance, at the evolution of mitral regurgitation after MitraClip in the French study, you can see that at 1 year, about 50% of the patients, they still have mitral regurgitation 2+ or greater after MitraClip. And if we look at the COAPT trial at 1 year, 31% of the patients still had at least 2+ or greater residual or recurrent mitral regurgitation. So this means that residual recurrent MR is still present at 1 year, at least 2+ or greater, in 1/3 of the patient in the COAPT and about half of the patients in the Mitral. Now, the higher the severity of mitral regurgitation, the higher it is probably the expected benefit of its reduction with the MitraClip procedure, particularly if the left ventricle is not too remodeled. So somehow this is a point where COAPT and Mitral they come to the same conclusion. Interestingly, if you look in the COAPT patients, at the subgroup of patients who had less severe mitral regurgitation, so effective regurgitant orifice equal or less than 30 square millimeters, you see that in this specific subgroup of patients, particularly when the left ventricle is more dilated, there is no difference in the two groups. And this is somehow replicating the results obtained in the Mitral studies. So what Mitral and COAPT seems to suggest is that severity of secondary MR appears to matter. It seems to be important the size of the left ventricle. Probably patients who have less severe secondary mitral regurgitation and larger ventricles are not responders. And maybe the best target is indeed represented for MitraClip therapy by those patients who have more severe secondary MR and still relatively small ventricles. This is in agreement with some data which have been published, for instance, by Goliash and co-workers in the European Journal just last year, showing that the most important prognostic impact of functional mitral regurgitation in chronic heart failure indeed might be present not in the more advanced stage of the disease, but let's say in a kind of intermediate phenotypes, in patients with relatively smaller left ventricle, in patients who are not in 4th functional class, but in those who are in 2nd and 3rd class, and in those who have an ejection fraction not lower than 30%, but between 30 and 40%, which means that in terms of prognosis, intervention in functional mitral regurgitation appears to be more effective in, let's say, an intermediate phenotype rather than in a very advanced one. This is the table reported in the study, and you see that the impact on the outcome of secondary mitral regurgitation was more pronounced in patients who were in functional class 2 or 3, p-value are significant, not in those who were in 4th class. And also in terms of left ventricular ejection fraction, the prognostic implication of secondary MR were significant in the patients with an ejection fraction between 30 and 40%, and not in those who had an ejection fraction lower than 30%. Also in terms of NT-proBNP, the most important prognostic implication of secondary MR were observed in patients who were in the 2nd quartile of these proBNP, let's say, values. So if we are going somehow to try to select the right patients for MitraClip intervention, summarizing the data we've been accumulating so far, probably patients who can benefit most are those with secondary mitral regurgitation with MR, which is at least, according to the American guidelines, 3+ or 4+, moderate to severe or severe, which means at least a regurgitant volume higher than 45 milliliters or an effective regurgitant orifice area more than 30 square millimeters, in a functional class 2 to 3, with an ejection fraction at least 30%, and possibly relatively small ventricles. We know that many other studies have shown that there are a number of predictors of adverse outcome after MitraClip. Some of them are right ventricular dysfunction, which is associated, of course, with the worst outcome after MitraClip therapy, pulmonary hypertension, cardiorenal syndrome. Those are predictors of poor outcomes after MitraClip. If we add those predictors in the table we were trying to figure out before, maybe the patient who could benefit most for a MitraClip intervention is, again, a patient with severe secondary MR, functional class 2 to 3, ejection fraction under 30%, relatively small left ventricle, possibly no severe left ventricular dysfunction, no severe pulmonary hypertension, no significant renal dysfunction. So the COPT study is very important because it showed that MitraClip improves the prognosis of a specific subgroup of well-selected patients. Those patients have to have at least 3+ or greater MR according to the US guidelines. If, of course, in those patients, there is an effective reduction of MR by using the MitraClip. Such a reduction of secondary MR does not seem to be beneficial in presence of less severe degree of secondary mitral regurgitation, particularly in presence of more advanced remodeling of the left ventricle. So we have to look, and we are still looking for the best target population. And the current evidence really reinforced the need of a very selective approach based on the heart team decision-making process when we need to decide in the individual patient which therapy will be more beneficial in presence of secondary mitral regurgitation. So again, as for surgery, also for transcatheter treatment of secondary mitral regurgitation, one size does not fit all. And I think that this is my last slide, that we can conclude this talk.
Professor?
Yes, I can hear you, Marcin.
Thank you very much for this excellent lecture. We see not only residents, but some surgeons here in the YouTube live. They are congratulating you about this lecture. It was really excellent.
Thank you very much.
We had some cases, we had some questions, and let me get into the first. So we have a question from the surgeon called Rodrigo Souza, and he's giving us a case scenario. There is a male, 17 years old, with dyspnea on exertion since 5 years old. His transesophageal echo is with the left ventricle function 24%, left chamber dilatation, severe mitral regurgitation, mitral valve mild thickening. With which procedure he's asking you would you suggest? It's not too much things to you, but which procedure would you suggest? There is no dysfunction in the right ventricle, but his pulmonary artery pressure is 82.
82?
82, yeah.
82. So he has got very severe pulmonary hypertension.
Yeah.
And severe left ventricular dysfunction, you told me, is 24%.
Yeah.
Ejection fraction. We do not have any data in terms of what I presume is a very advanced remodeling of the left ventricle. Do you have any diameter volume or anything available? Not.
No.
The patient is an ischemic patient or let's say primary dilated cardiomyopathy patient?
I think it's a primary one.
Is a primary one. He's 70 years old.
70 years old, yeah.
Do we have any data in terms of left ventricular bundle branch block dysynchrony? Is this something we know about this patient or not? Does he have CRT or anything else? Anything from that point of view? We don't know.
Yeah, maybe he have, but he just wrote this.
Well, I mean, of course, first of all, you should assess if there is dysynchrony, if there is any possibility in terms of, although the situation is very advanced in terms of helping LV performance with a CRT, ICD CRT, that's something you should be aware of in terms of, let's say, therapeutic options. Then, if you are, if that is the case, probably I would go for that and see after a while what is the improvement, if there is an improvement, in terms of degree of mitral regurgitation. If there is an improvement, then the patients can be, let's say, followed with medical treatment, but I would be very surprised that from severe mitral regurgitation, just by using CRT, the patient improves so much that nothing is, let's say, required to improve his secondary mitral regurgitation. So the issue here again is that we do not have enough data, so you could consider MitraClip, although in presence of such a severe left ventricular dysfunction, it is very doubtful the fact that this is going to be beneficial. But I don't think that we can discard this option, particularly if ejection fraction is improving after CRT treatment. So I would assess the possibility of CRT treatment if the patient has got left bundle branch block and dysynchrony. After that, I'd look again at the degree of LV function, particularly if there is some degree of reverse remodeling and in terms of function of the left ventricle, there is an improvement. Then I would assess the eligibility of the patient for a MitraClip procedure, which I would consider. Of course, it is very concerning the extremely severe pulmonary hypertension, but you still can see after MitraClip, you can use MitraClip, let's say, as a bridge to something else. The patient is not extremely old, he's 70, and in my institution, unless comorbidities are very important, he could still be followed up for a potential LVAD implantation as a destination therapy. If, as it would be in Italy, heart transplantation would not be an option, particularly in presence of that severe pulmonary hypertension. So still, I mean, also in terms of LVAD, this remains in the let's say armamentarium of possibility in perspectives. But I will go step by step according to the process I told you.
Okay. We have another question. Dr. Magalia Reis is from São Paulo. She's a doctor from São Paulo, from the Dante Pazanese Institute, and she have a question. In your opinion, do the results of COAPT and MITRA demonstrate that the correct evaluation of and indication of a procedure are the key points to obtain a better result?
Oh, there is no doubt from that point of view. The real issue is that the two populations of the coapt and mitral FR, they are somehow different, as I try to underline in my presentation, but not extremely different. I mean, what is more striking, in my view, is the fact that the severity of mitral regurgitation, according to the different criteria used in US and in Europe, is to me influencing very much the results. So if you have a very severe MR, which means according to the American guidelines, more than 0.4, and the left ventricle is not too advanced in terms of dysfunction remodeling, probably this is a population where we can get a benefit from MitraClip, because we are able to decrease, if not abolish, severe MR to moderate or possibly mild MR in presence of a left ventricle which is not too dysfunctioning or too remodeled. If we target those patients when they are too far, which means too advanced LV remodeling and dysfunction, particularly if MR is severe according to the European guidelines, which means that the ERO is more than 0.2, not more than 0.4, probably in these patients we are not able to provide a real benefit in terms of prognosis. The data from the Goliath study published in European Heart Journal, they seem to confirm this, let's say, consideration. The prognostic impact of secondary MR is more pronounced when the situation is not advanced. Functional class is 2 to 3, ejection fraction is between 30 and 40, NT-proBNP is not extremely high. So we need to intervene earlier in terms of LV function remodeling, but MR need to be severe. Otherwise, probably the procedure is not really impacting the prognosis. Those are just, consideration, trying to understand, to explain what is not easy to really clarify, because the trials, as we pointed out, they provided completely different results and conclusions. Did this answer your question?
Yeah, for sure. The first and the second one. In the second one, she would ask you, when do you recommend a MitraClip implant to get a better result? I think we discussed that.
Yeah, if we need to summarize, that's to me, the patient for whom I would expect the most important benefit is exactly what I told you. Severe MR according to American guidelines, relatively small left ventricle, symptomatic but not in fourth class. That is probably the best target.
Yeah, class 2 or 3.
Class 2 or 3, yes.
And 30 to 40%.
More than 30% ejection fraction. Yeah, that's probably the target. Now, yeah. Before we were already considering in the past about the possibility of treating those patients with MitraClip a bit earlier. But what is important? What is the important message to me from the trials is that it is certainly important to have left ventricles which are not too dilated and not too severely dysfunctioning, but it is equally important to treat MR which is severe. Because if we start with the moderate MR and we decrease these to some, let's say, mild, the implication in terms of prognosis of this small decrease of MR is not equivalent to the one you'd get if starting with very severe MR according to the American guidelines and decreasing it to moderate or mild MR according to the American guidelines. I think that it is mandatory that we have a unique definition and quantification of secondary mitral regurgitation. Otherwise, it is very, really difficult to understand the results and to understand the target population, because everything becomes much more confused.
Professor, I thought that it was very interesting, your slide when you showed the lottery around the treatment to the mitral regurgitation in UK. We saw some places that they do around 100%, over 90% of repair, and other two ones that they just replace the valves. Maybe Brazil right now, it's more close to these two down below, you know, just doing the replacement. I don't know why. You also show in the beginning of your presentation that the expertise, it's very important. And I could see this when I went into San Rafael. How do you respect mitral as maybe the more complex structure inside the heart, and maybe we still have to develop our skills and to have this goal to understand the importance of the repair and to try to go further. You know, we are just replacing the most part of our mitral valves here.
This is a very important point, Marcio. I briefly showed a few slides from that point of view, but really mitral repair is a specialty within cardiac surgery. To have enough experience to be able to repair the valve, you have to be lucky enough to be working in a high volume centers, because you need a very good exposure to this type of surgery. We usually forget, or sometimes forget, that mitral repair, although there are no randomized trials in degenerative MR randomizing patient to replacement versus repair, in degenerative mitral regurgitation, repairing the valve restores normal life expectancy. So it's not just a matter of quality of life, avoiding anticoagulation, better preservation of LV function. It's a matter of restoring normal life expectancy. So these are very important endpoints. And of course, it is still a problem, the fact that in any region, in any country, the almost 100% rate of repair is achieved just in a very few selected specialized centers. So really, since this is a talk we are having with cardiac surgery trainees in your beautiful country, I really would like to suggest and recommend you all to focus on this. What you need to do to increase in your own country the repair rate is to go to a center where this specialty of mitral repair is very well established, where you have many hundred of mitral repair procedures per year. Then you need to stay there long enough to learn about this type of surgery. And then, of course, you can very quickly reproduce back home this type of surgery. On the other hand, this has been very nicely shown by David Adams in the paper I showed you in my slides. If you try to go through this process on your own, of course, the learning curve is going to be very long, very steep, and very difficult. The way to overcome and make it very short is really to go in a center where this expertise is present, and in a relatively short time frame to see many, many cases, be involved in many, many of those procedures, and then it is something which you can easily apply back in your own hospital. That's my advice. Today we talk about minimally invasive approaches and solutions and so on. But what we really should focus on is that what changes the life expectancy is really the repair of the valve and the durability of this repair. Of course, if this can be done with a minimally invasive approach, that's very welcome. We should offer this option to our patients. But it's the quality of the repair which is going to impact the survival expectancy of our patients. So we should never forget about the really important things when taking care of our patients.
Yeah, these days we were discussing in a group of residents, maybe in a big group, around 300 residents, something like this. We were talking about the challenge to become a surgeon of the future, just to understand all the transcatheter techniques, and we are always concerned to be better to the patient, but we forget about the structural disease and how complex we can be, and how we can improve our techniques in a simple subject like mitral, and not just concerned about mitral clip or milliped or TAVI, and we still can be very complex and go very deep in these subjects like the mitral valve repair. State of art. It's very nice.
Marcio, in every big institution, I think you have to be able to provide nowadays a really tailored approach to the patient. I'm sure that Professor Raffieri, who is my master, he has been telling me for many, many years that all our efforts have, of course, to be patient-centered. So we have to tailor our approach to the individual patient. In your institution, any big institution, you have to have all the options available, from conventional surgery, minimally invasive, transcatheter, hybrid, whatever. But then you cannot do everything. You have the degree of specialty which is currently required in our field to do as in the best way possible. The procedure, the operation, the treatment, so on, is so high that you cannot be too much multitask. You cannot do everything. If you want to be able to repair the mitral valve in almost 100% of the cases, you need really to specialize in that. You need to dedicate most of your time to that. So I find it relatively difficult to think that you can be a very good, let's say, surgeon with valve sparing procedures, and then a mitral clip, and then TAVI, and then a surgical mitral repair. It's too much. So, of course, those options have to be available in your institution, but then you need to focus on your specific field of interest, and in that one, really to be specializing as much as possible. Really, mitral repair is a typical example of that. It's a specialty, and the different repair rate I showed you is basically related to that. In those institutions where there are surgeons who have been exposed to this type of surgery in a very intensive way, they've developed a kind of a degree of specialty, making them able to repair the valve almost invariably. When you do that, time to time, half and half, a bit of that, another bit of the other thing, and so on, you cannot become excellent, in my view, in one specific field. It's very difficult. That will not be possible for me. I hope it is possible for other more, let's say, bright colleagues. But as a general recommendation, I would suggest you to specialized in a specific field. And mitral repair is a very important one because we are dealing about quality of life and life expectancy. So if in Brazil you are going to improve that point, you are doing something which is extremely important for your patients, extremely important.
Very nice. And I think we'll still have time to hear by you a last message for all the residents of Brazil. For sure, what you could say for us, you know, like a last message for the young surgeons.
Okay. Well, first of all, be enthusiastic about your job. I mean, you have been choosing a work which is bringing on your shoulder a lot of responsibility, but at the same time, it's a wonderful job. Of course, this is a time of revolution, and it will be more and more, to me, in perspective, a revolution in our field. We should be happy for that. We should not be concerned about new technologies and new possibilities. We should be on the front line in the field of development of new technologies and new options for our patients. And generally speaking, I think that in the future, there will be a great need of very experienced surgeons on one side, being able to perform very complex procedures. And at the same time, there will be an important need of specialists in really minimally invasive approaches, which means beating heart, transcatheter, no cardiopulmonary bypass, and so on. That is the way this profession is going to be done in the next, let's say, 10, 15 years. So there will not be probably a simple aortic valve replacement anymore. You will need to be expert enough to be able to perform aortic valve replacement in a patient who has already undergone one TAVI and one valve-in-valve procedure, which is going to be a complete different operation as compared to the isolated AVR we are doing today. So on one side, you need to be a very experienced surgeon in, let's say, heavy, important, major surgical procedures. And on the other side, you need excellent professionals in the field of transcatheter options, which there is no reason they should not be performed by surgeons. I mean, those are in the setting of a heart team. So we really need in the future to look at this job as a team effort, joining cardiologists and cardiac surgeons, and being very optimistic, because we will be able to provide treatment for patients who so far have been refused because they were considered not operable. In the future, they will have more options that they've been able to receive so far. So be enthusiastic, be curious, do not forget about science. So look at your results, put together the outcomes, go around the world, tell others what you have been learning. Don't be simply a, let's say, an operator, but also a scientist, and try to bring all those things together, never forgetting that what we do is to take care of patients, and we have to be able to do that with as much love as we can, because at the end of the day, that's what we do, and that's the reason why we have been all choosing this job. That's what I really think in the deep of my heart. Okay, Marcio?
Thank you very much for this message. Thank you very much for your time and this great lecture. For sure, this will move us forward. I believe in that.
Marcio, I would like to congratulate you for all you have been doing. this is really something which is extremely important and useful to not only trainees, but also to all those, let's say, surgeons or cardiologists or family doctors who are treating patients together. So really many congratulations for an excellent initiative, which I would really love to be able to replicate, if not in Europe, at least in Italy. And my best wishes to all of you also for Merry Christmas and Happy New Year. Thank you very much for involving me in all this. Thank you.
Very much. Nice holidays. Best wishes for you and for your family too. Thank you again for your time. And I hope to see you soon, Professor.
Thank you very much, Marcio. Thank you. Thank you. Merry Christmas again. Bye.
Have a nice day. Bye-bye.
Bye.
Ciao.
Ciao.